travels through these bronchioles and reaches the alveoli, each of which is surrounded by a network of capillaries. A section of one alveolus shows the presence of numerous alveolar chambers with pores. Blood containing RBCs is seen flowing through the capillaries. The oxygen molecules from the alveolus diffuse into the capillary and then get absorbed by the bluish-purple RBCs. This causes oxygenation of the RBCs, and a transition in their color from bluish-purple to red is observed. The blood moving into the alveolus contains RBCs and carbon dioxide molecules. These molecules are released into the alveolus. The carbon dioxide collects in the alveolar chamber. And then from the alveolus, it travels through the bronchioles.
We will consider when to give oxygen to a child with an acute respiratory infection. The following clinical signs are used to recognize when oxygen is needed to treat a child. The presence of any one of these signs indicates a child needs oxygen. There are two main signs. First, central cyanosis. This is best seen by looking at the child's tongue in daylight or with light from an ordinary light bulb. Secondly, oxygen should be given if the child is not able to drink or has difficulty breastfeeding due to breathlessness. If oxygen supplies are limited, you should give priority to children with either of these two signs. If there is an ample supply of oxygen, you should also give oxygen to children with any of these clinical signs. In cases of severe chest indrawing, in cases of respiratory distress, or grunting with every breath if the young infant is less than 2 months old, or if more than 70 breaths a minute are recorded in a child aged 2 months up to 5 years. It's important that when oxygen is given to children with pneumonia, it is given continuously and not intermittently or for short periods.
Now understand the important points which are to be considered while administering oxygen by nasal cannulae. Fill the humidifier with distilled water so that the oxygen delivered is humidified and not dry. Set the flow rate to 0.5 to 1 liter per minute. Observe if the bubbles are coming out in the humidification chamber. Remember, the flow rate should be adjusted as hyperoxemia can be damaging to the infant. Position the baby in the same way as explained earlier. Use appropriate size nasal prongs depending upon the weight of the baby. These prongs are available in 3 different sizes, separate for the neonate, for a pediatric patient and an adult. Secure the nasal cannula properly to avoid accidental displacement. Assess the improvement in color and the signs of respiratory distress after starting oxygen therapy. Oxygen saturation monitoring should be continuous in an unstable baby. In stable babies, you require monitoring about 12 hourly. In babies who are chronically oxygen dependent, this could be done 4 hourly. This helps to ensure that the infant receives appropriate levels of oxygen. Adjust the flow rate so that the saturation is maintained between 90 to 93%. Is set 3 to 5 liters per minute. Observe if the bubbles are coming out in the humidification chamber. Remember, the flow rate should generally not be less than 2 liters per minute while administering oxygen by hood. Now, position the baby's head in the midline and keep a shoulder roll to keep the neck slightly extended. Keep the clean hood over the baby's head. The opening seen in the front portion of the hood should be kept at the level of the neck of the baby. Assess the improvement in color and the signs of distress after oxygen therapy has been initiated. If available, one should use a pulse oximeter to note the oxygen saturation. Adjust the flow rate so that the saturation is maintained between 90 to 93%.